Hello my friends, hello my colleagues, hello everybody. In a previous presentation, I talked about the clinical aspects of Alzheimer's disease. Today we are going to continue this topic and to talk about the treatment of Alzheimer's disease. So our presentation today will be about the role of pharmacists in the treatment of Alzheimer's disease. Okay? Now, we'll be talking about the pharmacotherapy or drug therapy of Alzheimer's disease. And we start with the first group. We call them cholinesterase inhibitors. Now, the cholinesterase inhibitors include Donepezil, Aricept, rivastigmine, Axilon, and galantamine, Remenil. Now, cholinesterase inhibitors, they inhibit an enzyme called cholinesterase. And when we inhibit this enzyme, we are increasing the level of the neurotransmitter acetylcholine. Okay? Now, the cholinesterase inhibitors, they increase the level of acetylcholine, okay, and they improve cholinergic neurotransmission, but they do not prevent the destruction of the cholinergic neurons. And the cholinesterase inhibitors can maximize the availability of acetylcholine. The cholinesterase inhibitors, they differ slightly in their pharmacodynamic and pharmacokinetic profiles. So if we start with the drug Donepezil, this drug is highly selective to the enzyme cholinesterase. It inhibits selectively the enzyme cholinesterase. And this drug is available as Aricept, and we have two strengths, 5 milligram and 10 milligram tablets. And the dose of Donepezil usually start with 5 milligram daily for 4 to 6 weeks. And if the patient tolerates this dose, the dose can be doubled after 4 to 6 weeks to 10 milligram. So it's very important to start this kind of therapy in conditions that could be exacerbated by cholinergic stimulation, because here we are going to increase the cholinergic stimulation, we are going to increase the level of acetylcholine at the neurotransmission. So the conditions that could be exacerbated by cholinergic stimulation include seizure disorders, asthma, dysrhythmia, or we call it cardiac arrhythmia, urinary retention, and active gastrointestinal ulcers like active peptic ulcer or active duodenal ulcer. Now, Donepezil is metabolized by cytochrome P450, 2D6, and 3A4. Now, the common side effect of Donepezil may include nausea, diarrhea, headache, insomnia, and pain. Now, the other drug, which is also a cholinesterase inhibitor, is rivastigmine, which can inhibit both cholinesterase and butyryl cholinesterase. In other words, it is less selective compared to Aricept or Donepezil. Now, rivastigmine is not metabolized by the cytochrome P450, and we expect here less drug-drug interaction with the drugs that are usually metabolized by cytochrome P450. Also, rivastigmine does not undergo hepatic metabolism. It undergoes non-hepatic metabolism by the esterases. Now, rivastigmine, which is available commercially as Exelon, is available in different formulation, capsules, and we have oral solution, and also it is available as transdermal patches. Now, the initiation of this kind of therapy, we start with 1.5 milligram twice daily for 4 weeks. And if this dose is tolerated, we can increase the dose by 1.5 milligram every 4 weeks until we reach the maintenance dose, which is usually between 3 to 6 milligram twice daily. Now, also rivastigmine can be used as transdermal patch, and we start with a transdermal patch of 5 milligrams strength to be used once daily for 4 weeks, and if this dose is tolerated, we increase it later on to 10 milligram daily. Now, rivastigmine is recommended to be taken with food to reduce the peak level and to lower the gastrointestinal side effects. Again, rivastigmine should be initiated cautiously in conditions that could be exacerbated by cholinergic stimulation. So the common side effect of rivastigmine may include nausea and vomiting, diarrhea, headache, and possibly dizziness. Usually, rivastigmine transdermal patches have less side effect compared to oral rivastigmine. Now we move next to galantamine, which inhibits the enzyme cholinestrase, and also galantamine can induce changes in the central nicotinic receptors, leading to an increased release of acetylcholine. Now, galantamine, or it's available as Rimonil, is available as extended release capsule in different strengths. The regimen here for galantamine is to start with 8 milligram daily for 4 weeks, and if this dose is tolerated, the dose can be increased to 16 milligram daily for 4 weeks, and later on we can go up to 24 milligram daily if the 16 milligram was tolerated. Galantamine is not recommended for patients suffering from severe hepatic or renal impairment. Galantamine again should be taken with food to slow the rate of absorption and to lower the gastrointestinal side effect. Now, galantamine is metabolized by cytochrome P450, 2D6, and 3A4. The common side effect of galantamine may include nausea and vomiting, injury, headache, and dizziness. Now, rivastigmine could be associated with more nausea and vomiting, and therefore the target dose may be difficult to reach. So galantamine is associated with a higher incidence of gastrointestinal side effects. Now, both rivastigmine and galantamine should be given with food in order to minimize the gastrointestinal side effects. Now, rivastigmine is available as transdermal patch, and the transdermal patch is associated with less nausea and vomiting compared to the oral form. Now, Donepezil can induce insomnia, and therefore it is not recommended to be taken at bedtime. Usually we advise the patient to take Donepezil or Aricept in the morning. Now, cholinesterase inhibitors in general, they possess modest benefit for cognition in patients suffering from mild to moderate Alzheimer's disease. Now, the selection of the cholinesterase inhibitor depends on many factors such as the tolerability, the side effect profile, the ease of use, and the cost. Now, the benefit of using cholinesterase inhibitors in cases of severe Alzheimer's disease is questionable. Now, cholinesterase inhibitor therapy requires monitoring for efficacy and also for side effects. Now, the cholinesterase inhibitor therapy should be re-evaluated after 3 to 6 months. Now, according to the MMSE, we need to repeat this test regularly to help a clinical judgment to see if the patient is responding to the cholinesterase inhibitor therapy or not. And this test is not reliable for response monitoring because it lacks sensitivity and it has a modest benefit. Now, the other test which we talked in the previous presentation, we call it FAST, okay, it can detect changes in function. Now, we usually continue the cholinesterase inhibitor therapy to achieve stabilization, okay, and also to achieve slow in decline rate, and also we continue if the patient does not develop an unacceptable side effects. Now, the worsening of symptoms may develop within 6 months. So here we have two options, either to discontinue the cholinesterase therapy or to switch the patient to another agent. It's very important here to educate the patients and the caregivers about the realistic expectation of the therapy. Now, if there is no change, this should be encouraged, not discouraged, because at least here the patient is not deteriorating, is not getting worse, and that's good, especially when we are dealing with a disease that cannot be cured, and it is usually progressive in its nature. Now, the optimal duration of the cholinesterase inhibitor therapy is uncertain and unknown. We continue the cholinesterase therapy until the patient shows no more a clinical benefit. It is important not to discontinue cholinesterase inhibitor therapy if the patient is institutionalized. So if the patient, put in like the elderly home or the senior houses or in the hospital, there is no need to discontinue the treatment. Now, however, on the other hand, cholinesterase inhibitor therapy should be discontinued if the patient becomes bedridden, or if the patient becomes non-communicative, or the patient is unable to perform the basic ADL activities. Also, it is important to delay the discontinuation of the cholinesterase therapy for approximately 4 to 6 weeks after admission into a long-term facility. And the question here, why do we delay? Because when the patient is admitted to a long-term facility, we expect behavioral changes in the function of the patients due to the changes of the environment, the caregivers, and also the routine. Now, if after discontinuing the cholinesterase inhibitor therapy, we find there is a significant clinical decline, then we need to restart the cholinesterase therapy. Now, we can switch the patient from one cholinesterase derivative to another in some cases if there is lack of efficacy, if there is loss of efficacy, and also for safety issues and for tolerability issues. Now, before discontinuing the cholinesterase inhibitor therapy, it is important to consider dose adjustment. Either we may need to increase or decrease the dose depending on the situation. Now, it's important to wait at least 6 months before making any decision about the efficacy of the cholinesterase inhibitor therapy, because sometimes the effectiveness of this type of therapy may not be seen in the early stages. We may need to wait some time. We need to be patient with this kind of therapy before we decide that this therapy is useless. Also, the patients and the families should be informed when switching from one brand or from one derivative to another, because there is a possibility of deterioration. Now, switching the cholinesterase inhibitor therapy due to development of side effect requires washout period, while switching the cholinesterase inhibitor therapy due to lack of efficacy does not require washout period, and we need to avoid cognitive decline and to continue treating the patient. Now, we move next to another kind of therapy, and here we have a drug called Memantine or Efficacy. Now, generally speaking, when we activate the NMDA receptors by the glutamate, this will lead to enhancement of memory and learning. So patients with Alzheimer's disease, they have overstimulated NMDA receptors by glutamate, and this could result in damage of the neurons and this condition we call it excitotoxicity. We have excessive stimulation of the glutamate or the NMDA receptors by glutamate, and that could lead to damage of these neurons. So memantine here works by blocking the NMDA receptors, and this will prevent glutamate-induced excitotoxicity, and it will stop the damage of the neurons. So memantine monotherapy is recommended for patients suffering from moderate to severe Alzheimer's disease, and usually these patients may have a small beneficial effect regarding the cognitive function and the functional decline. The memantine monotherapy, when used in patients suffering from mild to moderate Alzheimer's disease, there is no beneficial effect on the cognitive function. Now, the benefit of combining memantine with a cholinestrase inhibitor is questionable. Now, memantine is usually well tolerated because it is associated with low rates of side effects, and it is available as 10 milligram tablets. The initiation of the treatment is with 5 milligram daily for 1 week, and then after that we increase the dose to 5 milligram twice daily for the second week, okay, and then after that the dose is increased to 10 milligram in the morning, 5 milligram in the evening for 1 week, and finally, if the dose is tolerated, it can be increased to 10 milligram twice daily. Now, memantine can also be given at a dose of 5 milligram twice daily in patients suffering from moderate renal impairment, where the creatinine clearance is between 40 to 60 ml per minute. And memantine is not recommended for patients suffering from severe renal impairment, and if the creatinine clearance is below 9 ml per minute. Now, the common side effect of memantine may include constipation, confusion, headache, dizziness, and possibly hypertension. Now, the other agents that may be used sometimes in the treatment of Alzheimer's disease may include vitamin E, ginkgo biloba, non-steroidal anti-inflammatory drugs, estrogens, and statins. Now, vitamin E at a dose of 400 IU or higher is not recommended because it may induce hemorrhagic stroke, and this could lead to increased mortality. So we should not use this dose. The dose should be less than 400 international unit. Now, the benefit of ginkgo biloba in the treatment of Alzheimer's disease is questionable. Possibly some patients may benefit, others may not. Both vitamin E and ginkgo biloba should be avoided in patients who are at risk of bleeding and who are on blood thinner like anticoagulants. Now, the common side effect of vitamin E may include weakness, headache, diarrhea, and stomach cramps. And the common side effect of ginkgo biloba may include seizure, dyspepsia, headache, and dizziness. Now, other medications were tried in patients with Alzheimer's disease, like the estrogen, the non-steroidal anti-inflammatory drugs, and the statins, and they did not show any clinical benefit. Now let's talk about the management of the BPSD, behavioral and psychological symptoms of dementia. Actually, most patients suffering from Alzheimer's disease, they suffer also from BPSD. Now, the symptoms of BPSD may include depression, agitation, aggression, psychosis, insomnia, and wandering. Now, the severity of the Alzheimer's disease may affect the prevalence of the symptoms. For example, depression is more prevalent in patients suffering from mild to moderate Alzheimer's disease, while other symptoms are common in advanced cases of Alzheimer's disease. Now, the BPSD are distressing and they need increased supervision by the caregiver. Now, the BPSD could be the leading cause of placing the patient in the nursing home. Now, the initial management of BPSD is usually non-pharmacologically, and if the patient does not respond, we move to the pharmacological agents. So let's talk about the non-pharmacological treatment. Once the BPSD symptoms are identified, okay, we need also to identify and eliminate the potential triggers of the BPSD. So we need laboratory investigation to rule out the common causes of delirium. We also need to review the patient medication and to monitor and check for drug-drug interaction, polypharmacy, and if the patient is using anticholinergic drugs or drugs that can cause anticholinergic side effects. Now, the potential causes of the BPSD include changes in routine, sometimes noise or overcrowding, and possibly pain. The other possible causes of BPSD may include constipation, loneliness, boredom, infections, and dehydration. So the general intervention to reduce the BPSD include simplifying the task by breaking them into small steps and also by using simple language with the patient. Also, we need to provide the patient with a routine. We need to use a simple language, and also we need a technique of distraction and redirection. Also, it is important to achieve regular orientation for the patient to time and place, and some strategies which are of questionable benefit may include reinforcement, music therapy, physical activity, simulated presence, and reminiscence therapy. Now, if the non-pharmacological approaches are ineffective, we move to use drug therapy. Now, the pharmacological interventions are recommended if the patient has behaviors that could disturb safety, or if these behaviors persist, and also if the behaviors could endanger the safety of the patient and the safety of other people. Now, symptoms which are expected to respond to pharmacotherapy or to drug therapy may include agitation, aggression, psychosis, apathy, and depression. Whereas the symptoms that are not expected to respond to pharmacotherapy include wandering, shouting, sexually inappropriate behaviors. Now, usually the brain of the patient with Alzheimer's disease, the brain is very sensitive to drug therapy, and it is very important to start low and go slow. We start with the minimal effective dose, and we increase the dose slowly and gradually. So here they recommend to start with approximately 1/3 to approximately 1/2 of the adult dose, and then to titrate the dose up slowly. We need to review the drug regimens every 3 to 6 months for both safety and efficacy. And after 3 months, if we achieve behavioral stability, then we can taper the dose and then withdraw the medications that were initiated for BPSD. Now, during tapering, if there is worsening in the behavior of the patient, we can still taper down and re-evaluate the patient. Now, some drugs which are used in patients with Alzheimer's disease are the antidepressants, and the mood symptoms are very common in patients suffering from mild to moderate Alzheimer's disease, and the prevalence of the mood symptoms in advanced cases of Alzheimer's disease are uncertain and sometimes difficult to recognize. So the depressive symptoms should be distinguished from the symptoms of Alzheimer's disease. Now, some of the drugs that are used for the treatment of depression in patients with Alzheimer's disease are the selective serotonin reuptake inhibitors. They are considered the preferred antidepressants for patients with Alzheimer's disease. The tricyclic antidepressant possess significant anticholinergic side effect, and they could worsen cognition, and therefore they should be avoided in patients with Alzheimer's disease. Now, the selective serotonin reuptake inhibitors, they have less anticholinergic activity compared to other antidepressants. Now, paroxetine has higher anticholinergic activity compared to other members in the group of the selective serotonin reuptake inhibitors. So both citalopram and sertraline are preferred for the treatment of depression in patients with Alzheimer's disease because they are effective and they are well tolerated. Again, both citalopram and sertraline are preferred in patients with Alzheimer's disease because they are associated with the least sedation and they possess a few drug-drug interaction. Again, these medications are preferable because of the minimal withdrawal effect when the patient misses a dose or more than a dose. Now, the early indications regarding the efficacy, here when we have improvement in the sleep, appetite, and energy, and the late indication of the efficacy, we expect here improvement in the mood. So the selective serotonin reuptake inhibitors should be used at least 6 weeks in an adequate dose to determine whether the regimen is effective or not effective. Now, also antipsychotics could be used for patients with Alzheimer's disease, and the antipsychotics may improve delusions, hallucinations, agitation, aggression, and sleep disturbances. Now, we prefer the atypical antipsychotics for patients with Alzheimer's disease to treat psychosis and agitation, whereas the typical antipsychotics are not recommended and they should be avoided because they could be associated with high risk of extrapyramidal side effect, cerebrovascular events, mortality, and worsened cognition. Now, the atypical antipsychotics usually have modest effects in patients with Alzheimer's disease. And drugs like risperidone or olanzapine can reduce psychosis and agitations in patients with Alzheimer's disease. Now, quetiapine is less well studied in patients with Alzheimer's disease. Clozapine has not been studied in patients with Alzheimer's disease. Now, if the patient does not tolerate or does not respond to risperidone or olanzapine, we try to switch the patient to quetiapine or clozapine. Now, risperidone is the only atypical antipsychotics approved by Health Canada for the management of BPSD in patients with Alzheimer's disease. Now, the atypical antipsychotics have less side effect compared to the typical antipsychotics only if the atypical antipsychotics are used in low doses, because if you use the atypical antipsychotics in higher doses, they may behave as typical antipsychotics. Now, the side effects of the atypical antipsychotics are dose dependent, including extrapyramidal side effect, confusion, somnolence, and falls, and that's why it's important to use low doses. Now, the anticholinergic effects could worsen cognition in patients with Alzheimer's disease, and that's why it's very important to use the lowest dose of risperidone. Now, the antipsychotic-induced akathisia could be misinterpreted as lack of drug effect, and the healthcare provider may increase the dose of the antipsychotic, and this will lead to worsening of this condition when we increase the dose. So therefore, it's very important to perform careful evaluation of the patients with Alzheimer's disease who require increased doses of antipsychotics if the symptoms worsens with increased doses. Now, there is a warning by Health Canada in 2005 about the atypical antipsychotics that these medications could be associated with higher risk of cardiovascular events and mortality, especially in elderly patients suffering from dementia. So following the warning by Health Canada, there were some changes in the recommendations for the antipsychotics, and they recommended them for only if there is a risk of harm to patient. Also, they are recommended if there is a risk of harm to others, and if there is significant distress, or if there is failure of the alternate treatments. Now, the atypical antipsychotics require monitoring, for some side effect like the metabolic syndrome, the sedation, extrapyramidal side effect, and also for their anticholinergic side effect. Now, when there is symptom improvement by the antipsychotics, this means that the treatment is successful. Now, the atypical antipsychotic therapy must be discontinued if there is no improvement with an adequate trial or if untolerated side effects start to develop. Now, the other drugs that may be recommended sometimes, or they have been tried for patients with Alzheimer's disease, may include trazodone, benzodiazepine derivative, divaloprox, carbamazepine, lithium, and bispirone. Now, trazodone actually has a questionable benefit for the management of agitation, sleep abnormality, and sundowning. The benzodiazepine derivatives are not recommended because they could be associated with risk of oversedation, falls, or worsening cognition. The benzodiazepine derivatives are recommended only if the patient is suffering from severe agitation and did not respond to other agents. Now, there is no evidence of efficacy for some drugs like carbamazepine, lithium, bispirone, and divaloprox. Now, lithium can be used to treat mania in patients suffering from Alzheimer's disease. Now, finally, let's talk about the role of the pharmacist. Now, the pharmacist can optimize the care for patients suffering from Alzheimer's disease. The pharmacist can discuss the risk and benefit of a treatment with the patient, with the caregivers, and also the pharmacist can provide the realistic expectation. The pharmacist can be involved in the management of the side effect of the medications, and also here the pharmacist should recognize drug-induced problems in patients with Alzheimer's disease that could induce cognitive impairment, falls, urinary incontinence, and fecal incontinence. So pharmacists should perform regular screening for problems either induced or exacerbated by medication, by herbs, or by over-the-counter meds. The pharmacist should encourage a health maintenance activity for patients with Alzheimer's disease, including exercise, routine immunization, control of medical condition, correction of hearing impairment, and correction of visual impairment. And the pharmacist can improve the adherence of the patient by providing medication in a blister pack or in dosettes. And also the pharmacist can provide counseling to the patient and to the caregivers. And this counseling should be done in a private area with minimal distraction and also by repeating the information. So the bottom line of this seminar, pharmacists can utilize their clinical knowledge and skills to optimize drug therapy for patients with Alzheimer's disease. Thank you very much for listening and watching, and I hope to see you again in another presentation. Have a great day.